Asa, we're waiting for two more presenters to log in, and they're logging in right now from Aga Khan and from Coast General. They're logging in right now. A pleasure having you this Monday afternoon. Today is a very interesting day. Today is a very interesting day. We'll be hearing from our nursing team, the team that is on the front line offering care to our patients. And we want to hear the experiences. I know there are many facilities right now countrywide that are managing patients who have been confirmed to have COVID-19 disease or persons under investigations, but we chose 4 facilities to hear from them. So we have Kenyatta National Hospital, we have Coast, representative from Coast General Hospital, we have Aga Khan University Hospital and Kenyatta University Hospital. We were not in a position to get everyone to share the experience, but if you're a nurse in this forum, if you're a caregiver in this forum and you've been giving care to the patients, we'd love to hear from you in the Q&A section. Just let us know how your experience has been, the challenges you've encountered, the joys you've encountered, and we'd love to just know how to be able to be in a position to assist you. So Diana Menya, we are seeing your complaint about CPD points. We will follow up with Dr. Online. That we partnered with Dr. Online to be issuing the CPD points for doctors and dentists, members of KMPDBC, for the pharmacy and pharmacists and pharmaceutical technologies. Those are members of the PPB. We have our team from KNH that is taking care of your CPD points. They requested that you give them a week or 2 to be loading your CPD points after a session. But for the doctors and the dentists, we expect you to get them within a day or 2 of attending a session. So we will follow that up. For the nurses, we are still following up with Nursing Council of Kenya about the code. We hear it's not as simple as we thought it would. The process is not as simple as we thought. So we're trying to partner with them and see how best to be able to issue you with your token number. But in the meantime, those who are within Nairobi, pass by, we will give you your signature. We will sign your book. For those who are a bit far, we still have evidence that you attended the session. So once we streamline that with the Nursing Council, we will be in a position to give you your token number. This week's schedule, yes, we will share this week's schedule. CPD points for physiotherapists. We would appreciate if you let us know how your process is. The physiotherapist, your regulatory board, how can we get them to accept the points? So if it's a book that has to be signed, you can pass by at the KNH Research and Programs Department. We will sign your book, but if we can issue it with tokens, we will appreciate. That is the easiest method for us. So let us know. Joseph Kingori, please let us know how we will be able to, how we can issue the points to you and whether they accept the code that we give out. All right. Maggie, are you ready? Margaret Ogonga? Okay.
Hello, I'm ready.
All right, I guess we'll start with you and then we'll go to Zedi Komen. I believe you're sharing almost similar experiences now that you're both coming from KNH. And
yes,
after that, we'll go to Alice Maura. We're still waiting for Astrid Nyange and Cornelia Uma to join us. But once they join us, we'll be able to get them on board. So Karibu Margaret and Zedi.
Okay, thank you and good afternoon everyone. My name's Margaret Ogonga. I'm a senior nursing officer working at Kenyatta National Hospital Infectious Diseases Unit. I've been working in this unit since 2015 after coming from West Africa to respond to the Ebola outbreak in Liberia. About COVID, we started having COVID suspects as early as January we were getting suspects. The samples were going to South Africa, and we used to take 3 to 4 days to get the results. So those were like 3 to 4 days long wait for the results. And our first suspects used to turn negative until when we got our first positive. Our first positive went to Mbagathi. She didn't meet case criteria because she had traveled from the US. And at that time, case criteria was anybody who has traveled to China. So just for formality purposes, and because she said she had a sore throat, we admitted her. We brought her from Mbagathi Kenyatta National Hospital Isolation Unit to Mbagathi to Isolation Unit in KNH. And surprisingly, she was the least of the patients I thought would turn positive. I remember putting her in her bed and telling her, I know you'll be negative, but if you turn positive, we will nurse you. Then I remember on 13th March, I was off. At around 11, somebody called me and told me, you guys have a positive patient. And she was the least of the patients I was expecting to be positive. Then I saw it on news. First I said, no, we don't have. Then later I saw it on news. And surprisingly, this patient who had traveled from the United States of America had turned positive for COVID. Luckily for us, I think because we were having patients as early as January, we were nursing all patients as confirmed. So I remember putting on my PPEs well, putting on my 95 well, and gowning well to receive that patient. Though at the beginning, I was starting to have doubts. Was I well gowned? Was I well dressed? Was my mask well put? Because we drove all the way with an ambulance from KNH, gowned in Mbagathi, and then came back with the patient to patient care. So I was like, during transfer, did I contaminate myself? And then I think because of putting on the mask, psychologically, I was having a cough. And I think this cough was when the president said we need EU, KNH, Mbagathi within 7 days. I was one of the people who were opening up the building. So I think maybe the preparation, the cleaning, and the paint, I already had some cold and cough. So bringing it that this patient also now, having nursed this patient, I also started getting worried. Could this cough be related to me nursing this patient? But I remember after some time I got tested, I was negative for COVID. And after that, now I was sure my donning and doffing procedures are right. And since that day, I've nursed over 100 patients who have turned positive for COVID. We do our testing 2 weekly. And so far, none of my colleagues, I just say the nursing team has turned positive for COVID. And it's mainly the protecting the face and washing hands. It doesn't even mean putting on these coveralls and anything. It's mainly the face and washing hands. I always make sure my eyes are protected using goggles, putting on my N95 mask well, and hand washing whenever I touch a patient and I touch surfaces. In KNH, when we arrive to work on duty every morning, we clean our surfaces using spirit or alcohol, or sometimes we use chlorine to clean all our surfaces, just so that just in case somebody has contaminated the surfaces, we are able to put away the virus. So my experiences have been nursing these patients. It hasn't been easy because most of them sometimes come without symptoms. So they tell you, sister, I'm doubting my results. So you repeat. So for starters, we were all, apart from doing the nursing procedures, we were counselors, trying to counsel these patients, telling them we turned positive and we are going to nurse you well. And I remember our first patients were not very sick. It's right now that we are getting very sick patients due to COVID. The very first few patients were fairly stable. We nursed them well, and most of them went home after 14 to 21 days. My experiences were started with stigmatization, and sadly, the first stigmatization was from colleagues. At first, it was if you're working in an IDU, you are infectious, you're not supposed to go to other departments, you're not supposed to go to other units, you're not supposed to go to the bank, you're not supposed to go to staff clinic, you're not supposed to go to, you're not supposed to use public transport. But when it now came out that these suspects were even being, patients were being confirmed in A&E, patients were being confirmed in casualty, it now I think changed everybody's scenario of COVID can get you anywhere. It can be in the community, it can be in A&E, it can even be in the ward. Maybe a patient came with different symptoms. Like now you're seeing even diarrhea and vomiting is a sign of COVID. Otherwise, then we're just saying difficulty in breathing and cough. Secondly, it's fatigue. When we started, we were a few nurses. I remember we were 10 before the numbers were added. So we were working longer hours, but as time has gone by, and our working hours have been reduced. though not to the maximum, but at least now the fatigue is being looked upon. Then we have rest and recuperation after working every 6 weeks. We go off for 2 weeks, and those 2 weeks you don't come to work. You rest at home and work. Another challenge is other services patients are not able to access other services. Sadly, if you're a COVID suspect or a COVID confirmed, maybe you need dialysis, you need to be done for surgery. Until we had the COVID theater, patients were having a difficult time going to theater or dialysis. But as time has gone by, I think different facilities, like the facility I work in, we already have a COVID theater. And right now, inside our IDU CCU, we've started ICU there. We've started dialyzing our patients, which is a plus. But I remember before, it used to take like longer to dialyze the patients. Then they were using the CRRT machine, which forces a nurse to be inside the ETU for longer hours. And for the nurse to have those PPs for those hours, it was a bit uncomfortable, and we were like worried our colleagues from renal unit will get infected. But as from last week, IDU CCU has one room that has been set aside to dialyze patients who require COVID suspects from COVID patients, COVID positives who require dialysis. And this has maybe added a plus in my unit. We also have a COVID theater. So experiences was mainly patients missing out on the right services because they have been marked to be having COVID. My joys are when our first patient, who was patient number 2, turned negative for COVID. I remember we celebrated. Then again, after that, we saw the patient number 1 and 3 turning positive. We saw them on TV. That I think was an excitement. It was like, imagine you nursing a patient for 20 days, seeing Italy, the way guys are dying of COVID, then your patient is going home. You've been with this patient for those 21 days, and they're like your daughter.
Hello? Hello, Maggie, we seem to have lost you.
Your sisters, your brothers, and then you see them going home. Then another joy is when there was a day we discharged. Oh, I'm here. Hello? Are you getting? Hello?
Hello, yes, we can hear you now. And
okay, so the joy is
do you have...
Hello, are you getting me?
Yes, we can get you now. Do you have any slides to share? Are you having any slides? Because we can't see them on the screen.
Oh, I don't.
Hello? Hello, Margaret.
I don't have any slides to share.
Ah, fantastic. Okay.
Hello?
Hello. Yes,
Hello?
just good.
I'm here. Are you getting me?
Yes, I'm getting you now.
Hello? Okay.
Hello? Yes.
Hello?
Yes, we can get you.
Okay. So my joys during this COVID outbreak is discharging our patients home. And I remember discharging our patient number 1, patient number 2, patient number 3. Those were celebrations. Our sadness is when we lose a patient due to COVID. And we've realized most of the patients we are losing have comorbidity. They maybe have diabetes, they have RVD, they have TB. And it is sad when you lose a patient due to COVID and you're unable to help them. Then another joy is I was waiting for a call from Kenyatta because I was like, I was almost like 50% sure I could turn positive for COVID. Because by that time, I think I'd nursed over 30 patients who were positive for COVID. But I protected myself, but as a human being, usually have doubts. So I remember I got tested and I was told my results would come out the following day. I was off. And anytime I was getting a call from KNH, I was worried, like, no, gosh, they're calling me to come and collect me. I have turned positive for COVID until at last I was told your results are negative. So right now I test myself every 2 weeks. And luckily for me, I've still remained negative for COVID. I pray to God that I remain negative for COVID. And to my colleagues, it's mainly putting on the masks, putting on the right masks, protecting your face and washing your hands. COVID is not contact. In fact, the coveralls we are putting on are not the right PPEs. We are supposed to put on the scrubs. And because right now we are being given the coveralls, I'm praying that one day, because they are a little bit uncomfortable, I'm praying that one day my institution or other institution would introduce the surgical gowns so that we use them and not infect ourselves, because COVID is not through contacts or bodily fluids. Then lastly, some of my successes is last week on 1st, I was awarded a presidential Uzalendo award by the president. I was so happy because maybe my hospital and the ministry were able to see the contributions us guys have made to be given this award. I remember I have contributed to some interim protocols in the Ministry of Health, like the case management protocols. If you look at the contributors, I am one of the contributors in that protocol, and many others. And this was like, the ministry was just calling you, asking you in West Africa, through your experience, what were you guys doing that we could do in Kenya? And, yeah, thank you.
Hello, Maggie. Hello. Okay.
Hello.
Yes, now we can hear you. Your network keeps on fluctuating, but now we can hear you.
Okay, I've just said that luckily for me, I've not tested positive for COVID. And last week on 1st, when the president awarded the Kenyans the COVID, the Uzalendo Award, me and some of my colleagues were awarded this award. And it's mainly for the work we have done in KNH. And we've been assisting the Ministry of Health with protocols and guidelines into nursing case management of COVID. And I think that was added to our contributions. That's why the president awarded us that award. And that is a plus to me, because right now, maybe it's a motivation, because now I have 2 awards. I have the HSC and the Uzalendo Award. And I'd just like to urge my colleagues, if you just put on your PPEs well and be confident and don't panic, it's always your safety first. Don't be in a rush to nurse a patient. It's your safety first. You will not be infected with COVID. Thank you.
Thank you so much, Maggie, for sharing your experience with us. And I understand the fear that you always have every time you see a phone call from the hospital. I also appreciate the braveness that you and your team have dealt with this new pandemic. We all didn't know how to handle it, but you've shown quite a lot of braveness handling this, and we appreciate you for that.
Thank you.
Yeah, we also appreciate that you're part of the team that went to West Africa to deal with Ebola, and you're sharing your experience with us. We appreciate that.
Okay.
Yeah, and thank you for taking care of your staff. It's a good thing when we hear none of your staff has been confirmed to have positive COVID-19. So we appreciate that you're taking good care of the staff out there in the KNH Mbagathi IDU. So now we'd like to hear from Zedi Komen. Zedi Komen is also one of our team, one of our hardworking nurses at the KNH IDU. So we'd like to hear our personal experience, what she's gone through, the challenges she's faced, and yeah, we'd just love to hear your experience, Zedi. Zedi, are you there? Okay, we seem not. Is Zedi here? Okay, as we wait for Zedi to join us, maybe we could hear from Alice Maura from KU.
Good afternoon, everyone.
Good afternoon, Alice.
Hi.
Hi.
I'll be discussing the experiences of nursing through this COVID-19. I'll definitely explain we ain't experts on what we have done, because COVID has really changed our perspective of practices through different experiences, that is through fear of unknown, anxiety, not knowing what to expect. And as we go through along this presentation, I'll expect feedback and also maybe questions so that we can be able to encourage each other for other facilities and also people to take this challenge up. Because nursing portfolio has been expected to do several nursing procedures, from triaging, and now who knew temperature will be taken from supermarket, from roadblocks, every other area that you go. But thanks to COVID, all those have changed. I will be able to go through some of the challenges that we have been able to to experience through the day, first day that we were called by the Ministry of Health, and the management was told that we'll be expecting patients. The first day we received around 13 patients that were confirmed. At that time, Kenyatta University Hospital was not testing, and we received 13 patients that night, and we had to evacuate most of our patients to another wing just to ensure that we don't transmit the infection to them. And it was really a challenge, especially from the staffs. We didn't know what to expect, and people were really worried. I remember that same day when we were told to move the patients, I personally moved to another department, and even with some other nurses, people are not ready, not knowing how to relate with each other, not knowing how to relate with the other staffs, not knowing how to even go home and behave because of the fears that we had. But we really had a supportive, especially from the Directorate of Nursing. People came in, and some of us offered to be the first people to nurse the patients. And for starters, we used to nurse the suspects only, until that day when we received the confirmed positives from KNH in Mbagathi. We have gone through some challenges that to include, initially we had few nurses, but as you know that KU just started the other day, but we also kept on receiving nurses batches each and every other day. And the hospital was on it and up to the game, and they were able to always provide us with extra and enough staff to ensure that we are not very overwhelmed. The other challenges that we experienced was staying on PPEs for long, because in KU we didn't have a ready IDU. We were operating from the wards that we had to modify them to be where we'll be keeping the patients. And so maybe modifying the donning areas, modifying the doffing areas, but that also have worked because our IPC team was on top of the game, and they ensured that all of us were doing the best and ensuring that we are not transmitting and infecting each other. Then also the other challenge was being away from families that created high levels of stress. Without the roadblocks, and especially some of us work from other counties, and we experienced the roadblocks, especially maybe from Thika Road and even from other areas. But the hospital really supported us by getting a letter from the CEO office, and the management team gave us the letter so that we can be able to travel and see our families when we are tested, and when we test negative, people will always travel. Then also the fear of getting positive. Each and every other time, people will always fear receiving calls from the facility, any other person who is in management. If you receive a phone call from our doctor who is in charge, and even the director of nursing, people will keep on getting worried, not understanding how even to deal with the phone calls. But fortunately, they have been able to support the team all through, so that we are, at this point, people are just so energetic and happy of what we have been doing. The other issue was also the stigma from other staff, from other departments. You realize that when people know that we are working from the isolation ward, they don't want to interact with us. They don't want even to have any business with you. And especially if we could experience like an IT issue. But with time, when they also found that we are able to do it even from the clean area, and we introduced them and oriented them properly on how to don and how to doff, because we do it as a team. They came up, and most of the departments have been able to support us. Initially, when we started receiving clients in a hospital, most of the times we received patients from other countries, different nationals. We also experienced a language barrier, because some of the patients who came will not even be able to communicate in English. They will not be able to communicate in Swahili. and even for those other staff who are able to interpret for us, maybe in French or something, not everyone who was so willing to come to the isolation ward. Then the other issue that we had was having patients getting so agitated because of the long stay in hospital. You would find a patient some patients took so long to shed the virus, and there are, for example, a case scenario where we had one patient who tested 7 positives, and the 8th and the 9th test the test that tested negative. You can imagine now you test the initial test at 14 days, then 7, until the 7th, 8th, and 9th. That patient really, you can imagine the mental meltdown due to the long stay, and also the patients would get agitated. Some of them would get so rude to us, and the nurses sometimes really got demotivated because of this. You would go home feeling so bad, but at some point we were able to get the psychologist and the social workers coming on board, just to explain to the patients also that you're also going through the same. We are away from our families, and we can only work together so that we can be able to get to our goal. The other issue was the inconclusive results. When patients would get a positive result, they used to decline the results, and especially if there is an error, especially if you would have one of the patients, the age is different, like a name that was supposed to be Zachary, it was written with a L or a R, and the patients would not even accept those results. So we used to do some forced retest, not following the guidelines, because patients would not accept those results, and I could always make sure that they come to where to inform the managers that they need results as well. The other challenge we used to have is at some the initial stages, we could have suppliers bringing the PPEs that maybe were of poor quality, and at the moment maybe you are donning, that is when you realize, and that calls for so much wastage of the PPEs. Until that time now we'll have another supply, and that really affected our flow of work. But after some times, those are some of the issues that maybe in each and every other hospital can be able to check, and just to avoid in case they're taking up this challenge. The other issue was the social media majorly contributed to a negative picture, people not getting the right information, putting a whole facility at jeopardy with healthcare workers, the patients, the community, people not trusting us and not knowing what to expect from us, because they would think that it's either we are lying to them that this thing is there or not. And it was really such a big gap at that point, because of the negative picture that was given to us. Then also some of the good things that we really experienced was that from Kenyatta University Hospital, our leadership team, especially from the Directorate of Nursing, they've really supported us, and we are really appreciative of what they've done to us. And then also MOH, Ministry of Health, also in collaboration with Kenyatta University Hospital, offered psychological support to most of our patients. Initially, we would have patients getting so agitated because of the long stay, because of the way the patients have been separated from their parents and from even their children and from their loved ones. And the Ministry of Health came in and supported us so well in supporting, they sent quite a number of psychologists on the ground. Then also the hospital managed to deliver one baby through cesarean section, through continuous interdepartmental teamwork in the whole of the Kenyatta University. Then top-notch teamwork from the nurses, doctors, social workers, psychologists, other trauma, physiotherapy, and housekeeping departments. We used to go in as a team all through. And they could, we always encouraged each other to do together and to make sure that we are doing it together. The doctors would observe the nurses and the vice versa. The nurses would observe the doctors, and even the housekeeping team, the social work and the psychologists, the physiotherapy, in case there was need of such services. We would go in together and support each other, go into a room, serve one patient and move to the next patient, and move to the next patient together, so that all the services were delivered at the same point, and also to ensure that we do things very fast. Our doctors were very cooperative, even for turning patients, even helping us when we were doing some of the changing and all that. We really appreciate the doctors who worked with us, and even some of the members, like the physiotherapists and the social workers. Then the other experience that we had, the ability to accommodate staffs within the facility, to alleviate fear, to infect their families. Initially, when we were there was no accommodation of staffs in our facility, it used to make us feel so anxious when we are going home, especially for those who have young babies and pregnant wives, pregnant spouses and all that. But the hospital came up to support us in that, and we are really appreciative on what they've done for us. Also, the challenge of parents leaving their children, a case scenario of one lady who tested positive with her 2 daughters, and she had a 6-month-old baby at home who tested negative together with the husband. That lady would really struggle. We had to offer a lot of psychosocial support, because she had to quit breastfeeding, leaving her young baby with a husband who needs to work also to feed the baby. It was quite a challenge, but we always ensured that we are there to support them, and also to ensure that she didn't lose it, because some of these patients were really overwhelmed by what was happening. We thank the Kenyatta team, the Kenyatta National Hospital team, the Mbagathi team, the Ministry of Health, that really encouraged us. Always they would call and tell us the number of patients that we expect, and we would always prepare for that. So the collaboration and working together as a team from different facilities and from also the MOH team really made it easy for us, so that we can even have a smooth flow of services. The other challenge was, from a personal experience, how hard it was sometimes even to go home, and you don't even know how to whether to put on a mask when you have your family on board, whether to just stay like that. And sometimes it was really worrying, and let's say God has been with us all through, and we are happy for what you have done for this patient. We are looking forward to maybe if any other thing that would ever happen, like what you experienced at this point, just to encourage other nurses to consider following the guidelines, the hand washing, the use of sanitizers, proper teamwork, and just working together with the other team members on board, so that we can be able to achieve our objective. Thank you.
Thank you so much, Alice, for sharing your experience. We truly appreciate that, and we acknowledge that it has not been an easy journey. It has not been an easy task. I hope you're well.
Oh, yeah.
Yes, it's good to see the smile.
Yeah.
Now, the things you mentioned about the way things have changed, we're not doing things the way we were doing anymore. And also the issue of collaboration. So anyone who's listening from the county, please pick up some of the points that the presenters are mentioning, because you will experience it. When they started, it was only a few facilities that were handling this, but right now, quite a number of counties are handling the same, they're going through the same challenges that this team has gone through. So please listen in and see how you can partner with them, how you can collaborate with them. If you really do need to get in touch with them to walk you through the journey of how they've been able to protect themselves and protect their staff, get over the psychological challenges that they've encountered, and come out with good outcomes, then it will be good if you can be able to do that. It's good that we are learning from you, and we appreciate that you found time and were able to come here. So stick around for the Q&A session, but there's a question that Alice is asking before we move on to the next, and this is particularly to you. There's a part where you said you're away from your families.
Yeah.
Yeah, so is it that your family lives away from Nairobi, or are you provided housing at the hospital? Is the hospital accommodating you during this time?
Yeah, like personally, my family is in Nyeri, and I work in Nairobi because of we didn't really want, most of us didn't prefer to live away. You even realize that there are people who even got some small houses just to stay away from their families. But after some times, Kenyatta University Hospital was able to provide us with accommodation for those people who live with their young families. And for us who live alone, we can always go to our houses and ensuring that we have proper protection and not to transmit it, because you realize that transmission is all over for those who are using public means, even for when people pull transport just to drive together to work and back home. Yeah, but we've really gotten support from our facility that most of the nurses and the doctors and the housekeeping team were accommodated. But personally, I live in my own house because I live alone. I always prefer to go there, and also so that, because the hospital cannot be able to accommodate everyone. So for those who live alone, people are able to just give a chance to the few members who have families at home.
Okay, thank you. Thank you for sharing that.
Yeah.
We'll get back to the Q&A session. There are a few questions which we'll ask you to address, but you can just be going through them.
Thank you.
Astrid Nyange. Hello, Astrid. Okay, Cornelia Uma.
I'm here.
Yes, Cornelia, you can share your experience with us. Karibu sana to this forum.
Okay, thank you so much for inviting me to this forum. And before I start sharing my experience, I think I'll put up a slide and I'll be talking along the experience as you're moving along. So kindly allow me to share the screen.
Yes, you can share your screen. There's a green, yes, there, fantastic. Okay.
Can you see it?
Yes, we can see it.
Okay. So my name is Cornelia. I'm a nursing educator in Aga Khan University Hospital. I practice in the critical care unit. And I'll be sharing my experience, and I chose to use a slide presentation and talk through it as I'm going along. So, well, an overview of the disease when it started in March. And if you all remember, the coronavirus in Kenya came in March. But coming from our experience, having this pandemic being present in many other organizations and countries out there, even before March, we chose to actually, first of all, start putting things in place. So what the hospital did, even before we experienced our first case, we started having mini meetings. What do I mean is we have a standard mass casualty management mode in the hospital. However, in view of COVID-19, something that we did differently, we went back to our mass casualty review. We looked at what could have changed or what needs to be put in place in regards to the mass casualty. And we also asked all the departments to have their specific plans, because sometimes we have different aspects of care and different aspects of input from the different departments that need to be merged up in one. So with the guidance of our organization leaders, we actually sat down and talked through about it, and every department came in with their specific plans, so that it can be merged up to the overall hospital plan. So department, when you're talking about the plans, I'm talking about all the clinical and non-clinical department, because when you're talking about COVID-19, it is inclusive of all. So that was done much, much earlier. However, moving from that time to this time, we are still moving on to, well, improve the plan, change a few things here and there, just to accommodate all. Then when it comes to COVID-19, as nurses and other clinicians too, cannot forgo the chain of infection. It's our core thing, and we work around with it. So in our hospital, we try to look at all these other areas. What can we do in which area? What can we do to prevent something from moving from one area to another? Now, from the pathogen, we all know the pathogen is coronavirus, and well, that is there with us. In terms of reservoir and source, we now came up with the isolation rooms for all the suspects and confirmed cases. We looked at our capacity. Our capacity at the time, we were having a 300-bed hospital, but you're looking at our numbers in terms of human resource and what is the maximum number of staffs that you can accommodate in the event that you have a surge and you need to expand. So from that time, we actually went in and started setting up a temporary hospital in our, just next to our hospital. We call it a field hospital, just to accommodate them more. Now, in this field hospital, there's a clear demarcation between one patient to another, just to ensure that whether you're a suspect or a confirmed case, you are actually being cared for in different aspects, and the risk of contamination is very, very low. Then in terms of exit portal, route of transmission, entry portal and susceptible host, I'll be talking about it as I'm moving along. Now, we all remember the hierarchy of controls in regards to infection control. There is elimination, substitution, engineering, administrative controls, and PPEs. Probably maybe you have been talking much about PPEs, but remember all the others are quite stringent and quite important for us and all of us to actually look at it. And in terms of elimination, looking at the coronavirus, probably maybe we can discuss it some more, but there is nothing like eliminating the coronavirus. We can't substitute it or eliminate. We can only prevent it from moving from one area to another and manage appropriately. Now, in regards to engineering controls, there are many, many other things that you have put in place, and I'm also appreciating the many other organizations that have actually put the same thing in place. In the government, in the Ministry of Health, in the World Health Organization, we're being informed and also reinforced. We're also being told as an emphasis to actually take care of these other things. Like, for example, we are reinforcing on hand hygiene at all, in many, many places as possible, and also ensuring that this hand hygiene is not just the healthcare population, but healthcare and the community as a whole. So as a hospital, yes, that's, we are just reinforcing what we already had in place. In terms of the relatives and the visitors who are coming in place, is something that probably maybe you are reinforcing even more than what you had reinforced before, just to ensure that things are in place. In terms of seating, we used just to have seats for visitors, relatives, and any other person who is coming to visit us. But however, right now we have that 1 meter distance that you are putting across from one person to another, just to ensure things are in place. We are also trying to limit visitors, and I also appreciate my other healthcare workers who are also trying to limit visitors. The organizations that have actually kept patients' next of kin completely off, but however, in my organization, we have not completely kept them off. However, we are only allowing only the next of kin to visit the patient. For the other patients, these are the non-COVID patients who are in the organization, and we're giving them a maximum time of around 30 minutes to be in the organization, and then you're allowing them off. It's just an aspect of trying to cut down the interaction with people out there. Remember, when you're out there, you don't know who's positive, you don't know who's negative, you're interacting with everybody. We're going to the shops, we're going to the groceries, and we are exposed in many, many other ways. So we are trying just to cut it off. We've tried to get, like, for example, our critical care units. Initially, we had only 3 rooms that are negative pressure rooms for these patients. And those 3 rooms are the ones that were dedicated for the COVID-19 patient. That is for ICU, HDU, and other things also having theirs. But looking at COVID-19 and the aspect that we don't know where we are headed really, because the numbers are going up, and we may actually be getting higher numbers as they're going along. And even as I'm speaking now, we're also getting higher numbers in the hospital. So what we actually put in place again is to make all our rooms in the critical care area to be negative pressure rooms, just as a way of reducing the number of time, the risk of transmission of the microorganism from one room to another. And as much as healthcare workers are taking precautions using the appropriate PPEs, but however, there are many other things that you can also put in place. In terms of administrative controls, well, policies, procedures, training that is going on, being guided by our leadership team. Remember, initially I informed you about the mass casualty plan, and every department was tasked to have their own, which they did, of which we review as we are going by. And it is really helping us a lot, because using our operational team, which is led by our CEO, every week we're given weekly feedback in regards to where were we last week and where are we today, and what has changed, or what do we need to reinforce, what is our weekly tech this week. And in my view, it's working very well, because it's making all of us move into the one direction and pulling us all together so that we work as one unit in the fight of COVID-19. In terms of infrastructure, I've talked about the air. We have, in terms of the patients who will be in the medical surgical unit, not requiring the critical care per se. We have also, we have those dedicated rooms for those patients who are either suspects or confirmed. So all of them are being nursed on a separate room at the moment. And you also have another 100-bedded field hospital that will take care of the patients in case we have a surge. And those places are also separated by different aspects. And then for all these patients, like for example, the ones in critical care, we have one rule. We have dedicated equipments for them. So in case any equipment is moved to a critical care room where we are having a COVID-19 patient, and you're using those equipment for those patients, then it's not used for the other patients. It's dedicated for that, for those patients only. So with that aspect, you're trying to to share the equipments across, and you're trying to put all our patients who are COVID positive in one area, take care of them in one area with dedicated equipments, and those who are not having, also in another area with dedicated equipments to them. We've also, there are some patients, like for example, those who are, especially the ones in medical surgical units, those who are in the room, they're anxious. And sometimes if I can go by the experience of some of them, some people are just anxious. They're feeling like this is the end of it for them. They just want to talk to someone. And looking at our teams, we might not be able to go to the rooms all the time. So we've created a system, a communication system in the room. And the one, initially we're using telephone for those who are in the rooms and those who are outside the room so that they can communicate. But however, we have moved a notch higher and communicate and introduced a communication system that the patient in the room can actually communicate to the person outside without necessarily having a person outside come in, because it's not all the times that probably maybe you will go into the room to actually give any kind of intervention. At times it's just listening, having some kind of a chat, and sometimes they want to see you. So it's some kind of a video call or something so that you can see the patient, the patient can actually see you, and you can actually communicate. It's a way of allaying anxiety for them. In regards to nursing team, we actually trained all our nurses, because as much as we're talking about this pandemic that you're having currently, we don't know where we are going to head with this pandemic. That's why in terms of training, we'll do a day-to-day training with the nurses who are there with the patients who are already there. But however, all the others are also being trained, and they're also reinforcing on the training and refreshing. So we have online mode of training, and we also have one-to-one mode of training, because in case it spreads, like for example, let me use maternity as an example. A patient can come, probably maybe the patient is in labor, but however, again, the patient might also be having, might have been tested, and the patient turns out to be COVID positive. So what happens to such a patient? So in that view, all the staffs were actually trained with the notion that we don't know where we are headed, and we can't say that you're going to have only a small sector of patients, of nurses and doctors taking care of all these other patients. But however, it can cut across, and anybody at one point or the other might find himself or herself in it. So that's why we are all in it at the same time. In terms of communication, yes, you have that communication mode of between the the patient and the nurse outside, but equally we also have the communication between the, sometimes someone has gone in. What happens is when you're coming in the morning, we are trying to cut the number of times when the staff is required to go into the room where the patient is. Actually, the patients who have been actually tested and found to be positive. However, when the staffs are in the room, like let's say in the morning, there's we have had a round outside the room. We've discussed what we need to do on that day, the changes, what needs to come on board as one of the things, and the team goes inside. But however, there's a communication that needs to be communicated to the team outside. We have a clinical round, we have a doctor's round, and let's say it might be a group of, let's say 5 people, let's say 6 people. But those who are going in are not the 6 people, it's only a specific dedicated person. So one, the person going in terms of the doctors who are going to do the assessment is the one who is the most competent at the moment, so that they can go in, do one whole assessment, do interventions where necessary, and do as much as possible where necessary. The nurse and our unit assistants are also going to go in, and we're also going to do our nursing cares. We're also going to do our kind of interventions and whatever things we need to do at the same time. But at times, someone can be in and you want to communicate something outside, or maybe just seek some kind of communication. So we have dedicated communication boards. The goodness about probably organization is the rooms, especially in the critical care, they are glasses, so you can actually see what the person is doing inside if they have not drawn the curtain, and you can actually communicate outside. So with these communication boards, the person inside can actually communicate to you, and you can actually read what the person is actually communicating to you, and you outside can actually communicate to them. So that is in place, and even before that one, as much as we are putting a plan in place, we had a structured approach, so that when you are saying you're going into the room at 8 a.m., what are we targeting you to do? So we have a standard way of doing it, but however, remember, every patient is unique on its own way. So as much as we have this standard way that when you go in at this time, ensure you capture all these things, at times it might change depending on what the patient is having at the time. So it's something that you're working on and reinforcing on, but well, so far we have to say that it's working well for us. And again, thanks to our organization, all the patients, especially those who are coming for the inpatients, those coming for daycare, they're having COVID tests done for free, so that we actually know when a patient is coming to us, is this patient probably maybe at posing a risk, or all the patients, because generally, even before testing, everybody is guilty and is susceptible unless proven otherwise. So when the patients come and we do the test, and well, we find them to be COVID positive, well, we'll put in the precautions that we need to put in place. But those who are also negative, we'll also take care of them as we were supposed to take care of them, and do everything in place, and well, just follow through as what is expected for us to do. Then in terms of PPEs, one, we have our organization have worked with the different suppliers to have at any point in the hospital, we must have a 6 months supply of PPEs for the 400 beds. Now 400 beds is inclusive of the 100 beds that we have actually talked about, in terms of, in case we have a surge, that's where the other patients will go to. So in terms of our store, that is in place. 2, we must have controls for it. I know us as healthcare workers, and this is also something that you also underwent, is there's a lot of anxiety, and me as a healthcare worker, I'm feeling like I'm really susceptible, I'm really exposed to this, I'm having a lot of risks here and there. But however, as much as you're talking about that one, there is a rational way of using PPEs. There's a way we need to control, because as we are going through with this pandemic, we've seen in some of the organizations out there, and also some countries out there, they have come a point where the PPE is actually just not available. And we're trying to look at our level where we are saying, we want to protect ourselves in the best way possible. And we also want to use the PPEs in a rational way, so that we just don't misuse, and in future when we actually need it, it's going to become an issue for us. So that's one of the other things that you're working on. So we have a control That control is also being led by our chiefs in the hospital, so that you have a rational way of actually getting the PPEs, rational ways of using it. And it's an end-to-end monitoring for the PPE, so that at any given point, there's no misuse of it. And as much as we are not talking of no misuse, we are not also putting our staffs at risk. So we are giving them protections in very best in the best way possible, and we're also using the PPEs rationally. So one of the things is, if I can go by the face shields, we initially used the face shield that were disposable, but however, we've also worked with organizations out there. We've done our checks here and there, and we've come up with the face shields that can be reused. But however, reusing doesn't mean that I use and give the other one immediately. There's a cleanup process that is taken care, is done in between, but it's a face shield that can actually be used multiple times. In terms of the gowns, we are working with the local industry. Right now with the imports and other things, as much as you're getting 6 months supply, there's also that cut in terms of the supply might not be as best as the way it was before because of other factors that are also in place. So we are working with different companies just to ensure that we are getting the right quality. It's not just a PPE that is coming, but you're also assessing that this is the right quality, and ensuring, as much as we are assessing these, we already have our 6 month stock in place. This is just an addition in case our stock goes down and we need to replenish at any one point. And then for PPE, there is a strict buddy system, meaning that I'll go in, go into the room, I'll come out and doff. But however, especially at the doffing point, the risk of transmission is very high. And that's why you have a strict buddy system. When you are donning, there's someone who is actually getting you through the process one by one, taking you through the process one by one, and actually seeing that you're following through all the steps. And when you're doffing, that equally is actually in place. Just as a way of critiquing each other, ensuring things are put in place, ensuring that you're not swaying at one point or the other. And remember, with rules of PPE, any breach of the PPE at any point, like for example, I've gone into the room and for one reason or then another, I get a tear, or maybe there's a breach of a PPE at one point, I should change immediately. So that buddy system has really worked well for us, and we really thank our people in place for putting everything in place. So spreading of the COVID-19, well, can't forget that there's droplet, there's contact, and there's airborne precaution, especially when you're having aerosol producing procedures. But remember, even before we go to the transmission-based precaution, we must always talk about standard precautions. Hand hygiene, hand hygiene, hand hygiene. And remember, hand hygiene is it's either using the soap and water or alcohol-based solution. And remember, alcohol-based solutions, there's a certain standard that you're supposed to use. So right now, there's everybody getting all the sanitizers in place, but not everything is meeting the threshold that is supposed to be meeting. So one of the factors is whatever we are using within our capability in terms of within our environment in the hospital, it must actually achieve the standards that you have set in place. And that is some of the things that you are critiquing before we get things in place. PPE, I'll talk about it some more as you're moving along. Respiratory hygiene. Remember, as much as you're talking about COVID, this is in terms of taking to the community and going out there and teaching everybody. We are really in the center of it, and it starts with us. So as much as you're also going to teach your fellow colleagues about respiratory hygiene, you're also going to teach the population, those who are coming into the organization and those also out there in your different capabilities. Safe injection practices, very key for us. Sterilization, disinfection of equipment, very key, especially when you're using reusable agents like reusable equipment, like for example, as you're using the shields that are reusable. And that is one of the things that we really need to look at. How is the disinfection and the sterilization of all these equipments being done? Equally on that aspect, there's the environmental care. These patients are going to be in those rooms that I actually communicated about. But however, if a patient has recovered and the patient, or maybe has had a different outcome and we have moved the patient outside the room, that room has to be cleaned and prepared so that it's ready for the next patient. So what are the processes that you have put in place so that actually these processes are in there? So for us, we are using the sodium chloride solution to clean all these surfaces after every patient has left. And additional to that, once you have cleaned the rooms, you're using the UVC light technology just to ensure there is good disinfection. There's good, I'll say it's sterilization based on the UVC technology, the technology used that is in place, so that it's actually sterilizing all the areas of, maybe you are trying to reduce the number of microbes in the room or in the area where the patient was in the maximum way possible. So that's one of the areas that all our staffs, by the guidance of our engineering team, have actually sat down. We've actually had training and also having retraining and also reinforcement on it. And whenever we have to do that, we also have to use the UVC light. The engineering department will also be working with us. Will be there with us to monitor that everything that you have put in place is actually being done in the right way. And we've also done, just as a way of critiquing ourselves, we've done analysis of the data that you have gotten for those rooms that you have used UVCs. And so far, whatever findings you're having is actually what you actually desire, and you're working well with it. So that comes hand in hand with the environmental cleaning, where our housekeeping department is really, really, really neat. As much as we are going to be there, we're going to monitor them. They're also going to guide us. Anytime we need, one of the things, when you get a patient into the room, we try as much as possible not to move the patient out unless it's really, really necessary for that patient to go out. So most of the diagnostic techs, like for example, X-ray, we have a dedicated equipment for X-ray for those patients. And the machine will come, the X-ray will be done portable, and we'll have the analysis of results and many other interventions being carried out at the appropriate time. Now, again, with the environmental cleaning, in the aspect that I have a patient in the A&E and I need to move the patient from A&E to, let's say, ICU where I work. Now, along the way, there's a lot of surfaces, and probably me or someone else and someone else are going to touch all the surfaces. So one of the things about movement, 3 departments are really key involved. There's the nursing team that is involved in moving the patient. Our doctors are also going to be involved depending on what kind of patient. Sometimes we need to involve the doctor in terms of moving the patient, depending on the criticality of illness of the patient. We also need the housekeeping to clean the environment as you're moving along. We also need the security to keep the routes open for us, so that we try to use the minimum time possible on the corridor, so that we don't have bumping of everybody in place and moving patients here and there. So that is in place for all the suspects and those who are confirmed. Then you come to transmission-based precautions. So you're talking about droplet, contact, and airborne. And when you're talking about aerosol-producing procedures, that's the time when we are talking about our respirators. Our N95s and those who are having N99 also, this is where now we are using it in place. It's one of the things that we are really, 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 really working on. So this body system is really working out on us. In your plan of care in the morning, is any of these procedures going to be done? Remember, this is just one of the example of aerosol producing procedures, but remember, there are also others that can actually come in place. So if this is going to come in place, the body system that is actually in place where the donning is, at the point of the donning, the body will actually question what kind of procedures do you anticipate to do? And then that's when it comes to now use of a medical mask versus use of a respirator, it needs to be very clear, because if you are going to have aerosol producing procedure, now we need to use a respirator, and that has to be put in place. Now, this is just a photo to show one of the ways, and this is one of the ways that we are using to improve. Remember, when you're in all these PPEs and you're getting into the patient's room, patients are feeling one of the things, they can't really figure out who you are, because you are a bit covered with all these PPEs, and depending looking at our aspect of care, we really need to put on that. So it's also actually a way of allaying the anxiety and making them a bit calmer. We've seen some of us are using names. We are writing our names on the gowns so that they can actually know who we are. That is on top of us introducing ourselves, because we really need to introduce ourselves. But this is also another model where people have put actually their photos on their gowns, so that as much as I'm covered, you can actually see my photo. It's just a way of allaying anxiety and trying to reduce the anxiousness from the patient on the other side. So general principle of PPE is hand hygiene has to be there, pre and post. So it has to be there all through. Do not adjust and touch PPEs during patient care. Now, this is very, very important. Now, sometimes you go into the patient's room and you're having all these PPEs, and there are many other activities that you're doing, and you're sweating and you're feeling itchy here and there. You feel like adjusting something here and there. So that really puts you at risk. So it's one of the things that when we are doing all our training, when you're putting our policies in place, when you're talking about reinforcement, you're debriefing here and there, we really need to talk about it and reinforce on the aspect that do not touch any part of your body when you're having the PPE on board. If by any chance, like now, for example, if you, to remove or replace damage, there's a tear or something, or maybe there's a breach of PPE at any point, one point, just go out of the room, go to the ante room, doff, put in another clean PPE, because at the aspect where there is any breach of the PPE, then you are putting yourself at risk. Remove the PPE from the cleanest and the dirtiest to the cleanest. Well, there is a clear, when you're talking about this body system, when you're talking about the donning and doffing, you have a clear checklist that you're using. What comes first, what comes second, what comes last, how do you go about it, and you're doffing, that also comes in place, just to ensure that at no point are you probably having something done differently and putting yourself at risk. Then discarding the PPE very carefully, because if you throw it everywhere and throw it any hulabaloo way, well, you're putting people at risk and also putting yourself at risk. So I talked about this in terms of strategies of minimizing the availability of PPE. And remember, this is just from the, if I can go back to the source, this is directly from the WHO source, where we are saying that PPEs have to be used appropriately. Don't use PPEs everywhere and anywhere just because the PPEs are available, because you are also compromising the future of your care. You don't know what's going to come in next. Coordinate PPE supply, I also talked about it, and minimize PPE. Now, minimizing PPE needs is where now, like for example, our hospital, you're talking about telemedicine. Those patients were okay, and those who are coming for just a review of whatever, and they don't really necessarily have to be seen on a face-to-face basis by the different clinicians that are there. We really need to actually communicate to them at home and try to keep them at bay. Let those who require to come to hospital really come, but those who don't really require to come to hospital, we can actually reach out to them and actually get them their services outside the hospital environment. Now, again, minimizing PPE need, remember I talked about the communication between the patients in the room and patient and the nurse or the clinician outside the room, and you have all these call system, you have all these video conferencing system. It's a way of, probably maybe the patients just want to verbalize about something, but the fact that you're going into the room, you need to put on PPE. So the fact that this system can actually be used, and a good number of patients are really feeling comfortable with it, they're embracing it a lot, it reduces the need of PPE, and you can actually dedicate our care, give a dedicated care. We can give a very best care that we, as best as possible, and actually reduce the need of us putting PPEs just for going in to listen to one thing and coming out. So this is a target, rational PPE use. This is, I drew it from WHO website. And the last time they reviewed it was 6th April, and looking at it, just a few, like yesterday, they're still reinforcing on that. So in terms of screening, they're really trying to focus on the three things that we have talked about: minimizing PPE use and rational minimizing, controlling the PPE and rational use of the PPE. So here we're talking about the healthcare workers, and if it's a preliminary screening, they're saying we maintain physical distance of 1 meter. Ideally build a glass barrier, of which I would also appreciate my organization. They have put, like, for example, the front desk workers. There are a lot of barriers that have been put in a number of places, just as a way of trying to create a barrier from any other person who is coming to seek any kind of assistance to the person who is actually delivering the assistance on the opposite side. According to the WHO, at this point, no PPE is required. But however, if I go to our local requirement, remember our government has informed us that if you are in a public place, you need to put on a mask. So that the use of the mask is actually there in all the places. But however, if you go to the WHO organization, if it's just preliminary screening not involving direct contact, no PPE is required at any point at that time. If patients with symptoms are suggestive of COVID-19, still maintain the distance, provide a medical mask. And one of the challenges that I think we have is, especially with this surge of numbers and a lot of PPEs being produced all over the places, the quality aspect of medical mask really needs to be looked at. Because there is a number of medical masks being produced out there, but not all of them are meeting the quality. So us as a medical aspect, when you're talking about the PPEs, before we direct something to come to our organizations, we really need to critique and evaluate it from all the angles so that we get the right type of medical mask in our environment. Then move the patients to isolation room. Like for example, in our A&E, we have a dedicated room for those who are having suspect or the suspected cases or confirmed cases. We have a dedicated room for them. Again, goodness is this dedicated room is a negative pressure room, so that any kind of care, any kind of triage, any kind of assessment is going to be done in that place. Perform hand hygiene all through. Then patients without COVID-19, no PPE is required, and perform hand hygiene all through, but maintain that 1 meter distance. Now here, when you're talking about healthcare workers, if I can use example of organization, and probably maybe I'll introduce this in this place. The use of coverall versus the use of versus the use of just a normal gown. Now WHO says, if I can go to this one, WHO recommendation says that if you go back to our knowledge of Ebola virus, coveralls were the appropriate PPEs to use at the time. Double gloving, head covers, that's the hood, and others, it was the appropriate for that time. But however, what are we having right now? We are having coronavirus, which is a virus that is spread via droplet. And well, airborne precautions come in place when you're using aerosol producing procedures. And then there's also contact, because after you cough out, or maybe the microorganism comes out, it lies on the surface. Yes?
Hello, Cornelia, how are you?
Hi.
Thank you for the presentation.
Okay.
Yeah, are you almost done?
Yes, I'm almost done. I'm in the last one.
Okay, fine. Okay, yes. We'll give you like 2 more minutes.
Okay, 2 more minutes, that's fine. Okay. So here, probably instead of just going one-to-one, I'll just talk more about one thing, but we all remember that in the absence of aerosol producing procedures, you're using medical mask, gown, gloves, eye protection. It's basically covering the mucous membrane. And in case we have an aerosol producing procedures, we remember to use the N95 or FFP2 or N99, depending on what you have. Now, the aspect of the gown, me personally, I can use an example that I had. Initially, when it started, everybody was on the coverall, and if the coverall is not present, remember in this COVID-19, you are managing the patient and also managing ourselves. And there was this notion that I'm not comfortable if I'm not having the coverall. So it took us, it was an uphill task to change people's mind that you can use the gown, and actually gown can actually work out very well. And if I can use myself as an example, I've been using gown for all through. I've using the gown and the other kind of PPEs, N95 where necessary, gloves and eye protections where necessary, apron if you're having some kind of a spill. And I was tested along the way. And probably maybe I can say I can be a sample or something. And with the appropriate PPEs that I used with the gowns, I tested negative. So what does that, if I can use my personal example as one of it, even without the coverall, of which is not a requirement for the COVID-19, even with the gown, we actually protecting ourselves more. What we just need to reinforce is we have a rational way of using the PPEs. And the rational means that this is COVID-19, it's transmitted via droplet, airborne, and contact, depending on the circumstance that you're talking about. And the area that you're going to have the entry of the microorganism is via our mucous membrane, which is basically around this area. And when you're having the gowns and the hands are covered with the gloves, but remember, even before you put on the gloves, you need to clean your hands. We are well protected. So we really need to work on everything that we have. And looking at it globally, there are many other things that you can put in place. My colleague talked about psychological care and other things. I wouldn't want to repeat about it, but again, it's very important. Remember, as you're sitting here, we're also having our own fears. But as much as we're all having our own fears, we also need to take care of our patients. So well, in a brief, that was my experience.
Thank you so much, Cornelia, for sharing your experience with us. We truly appreciate it. It was well detailed, and you covered all the areas from entry point and up to the patient care that you're offering. And we truly appreciate that you took effort to come and make this presentation to us. One thing I've learned is you highlighted issues of dedicated equipment and family support. We also appreciate that you're offering that. And the communication system. It's a good point that we should all learn from that. Initially, you said you had telephone, but now you have video call where the patient can actually see you and communicate with you. You also talked about training of staff, and you mentioned that all your nurses are currently trained, and the reinforcement is still going on, no matter what department they work in, and a structured approach, so that as you go into the isolation room, you know what you're going in to do. So we truly, truly appreciate that. Even the PPE, the way you've discussed how you're using your PPE and rationales of PPE, we appreciate that. There are a few questions in the Q&A. My colleague, Dr. Nancy Ngumba, will take us through the Q&A section. I can't seem to find Astrid Nyange from Coast General Hospital. Would have loved to hear their experience. They've done quite a lot of work, and would love to hear the nursing experience there. So we'll ask Zedi Comment to share briefly her experience, and then Dr. Nancy will take us through the Q&A section.
Thank you, Dr. Ari. My name is Zedi Comment. Can you hear me?
Yes, we can. Yes, we can hear you, Zedi.
I hope you can hear.
Yes, we can.
Okay, thank you. Units, KNH at Gambagadi. And just the way my colleagues have shared, I'm just going to add on to the things maybe they to add on what they said. So when we started, it was really chaotic, and it was full of anxiety, because we didn't know exactly what COVID is. But basing on the knowledge that we had while managing patients who had Ebola in West Africa, then we were like the backbone of managing this disease. But I thank the IPC team in KNH who did a great job training everyone and retraining everyone on IPC standards, precautions, and telling us about COVID and how to manage COVID. So that fear was basically because of lack of knowledge, especially by the multidisciplinary team that we worked with, the team that I was working with. So it was a bit easy for me. So most of the challenges that we had were now managing the fear of the other staff, the other multidisciplinary staff, the lab, pharmacy, catering departments, security, and so on. Because at first it was like people really feared, and they were seeing death in front of them. Not saying that even to the strong team that we had, we used to sit and discuss our fears, and the psychological team from KNH organized for us a channel where we would communicate, allay our anxiety. And the other challenges that we had when we started were about the systems. We were still organizing for the systems to work, and the hospital management and the nursing department really did a great job by making sure that we had the SOPs that we need, the equipments that we need, the environment that we need, and that really helped us a lot. And as we continued, the improvements were made based on the challenges that we had. So after every challenge that we had, we were able to get a solution from it and learn from it and improve from that problem. So when we started, the patients who were there, there were very few, but now we can see the numbers are really going up, and it is still a challenge, which I know we are facing it day by day. And especially so now that we're seeing very sick patients, the challenges are being prepared on how to take care of these patients. Remember again, we have patients who have different illnesses, different ages, and that is still a challenge. Because as a nurse, we have our own specialties, and as an infectious diseases nurse, sometimes you may get a condition which you know, like, for example, you've not been managing that patient for long, then it needs you to consult and rethink and replan again, which has really helped us because we openly communicate, we openly consult, and those consultations have gained value to our management. Then the other challenges, we had patients from different places speaking different languages, and it was a real challenge to us. And it is something which came to my mind, and I thought, as a nurse or as a medic, we need to be flexible and learn so many other things, like learn so many other languages, even the sign language for those who cannot speak. And then many people did not know how to manage COVID, but we thank God for the continuous training and the webinars that we've had. It has really built us in how we can have many success stories to our management. So part of my success has basically been God. God has been very faithful to us. And every time we start our work, we start with prayers. That in a way helps us. Then we have a great support by the management through the office of the DNS. We usually have a weekly meeting. These weekly meetings basically discuss on the challenges that we have and plan of the things that we require in our hospital. We've had psychological care. This team has been very great to the staff, not only to the staff, but also to the patients. Remember, COVID has had a large impact on the mental health, and this is very important for anyone who is starting to manage COVID patients. Psychological care should come in first, especially in the manner in which you relay information when you give the results, before you test, and so on. There's a lot of anxiety in it. Then there should be a great teamwork. So that is part of our success. We have a great team in Bagadi. I have a large family, I would say, of pharmacy, the lab, and what has really helped us is when we want to go into the CTU, we go in as a team. So we plan our work. We know the patients that we have. We know the kind of need that they have inside. So we plan, and when we plan and go in, it really helps us so that we don't take a lot of time inside the CTU. Remember, again, taking a lot of time increases the risks and the anxiety. So this planning by the team has really, really helped. Then, of course, the other success is the support that we get from the Ministry of Health. They have really been on our doors, supporting us with most of the things that we require through our management. We have the IPC team, which has been our backbone, who has continued to train all our staff and retrain them. Anytime we feel that maybe someone needs more training, we call upon the IPC and they come in and to train them. So just the way Aga Khan are doing, we do our buddy system where we work in pairs. I take care of you, you take care of me. And that has been a very great success to us. Also, our families have been of support, and we thank God for them. Our families means even our friends who've been calling us and making sure that we are okay, we are psychologically healthy, and we've been sharing with them the information that we have and so on. So information is power. Let's share our information with anyone we have, our family, our friends, and so on. We've also managed to learn through the challenges that we faced. And these challenges have been the basis of our foundation, as considering the many patients that we have. We had at first patients who are very stable, and these patients had a lot of psychological issues. And just the way Agakan did, we have an open system where we communicate to them. We use mobile, and also we use open forums where we take them outside on a field. They are 1 meter apart, and they are free to air their grievances and their issues, and we're able to see how they are. And from there, then we plan on what their needs are. We also manage to have a support group for our patients. So we have a support group of the patients who have been discharged, and even those ones who are still in the unit. They are free to air their grievances. They are free to share their problems, and we've been able to help them through that system. And then the staff, my team, and myself, we've been able to discuss on how to take care of ourselves, and especially when we are off duty, so that we get enough rest. We do a lot of exercises, we eat well, just to keep us healthy and be ready for the next assignments that we have. So again, IPC, our IPC standards have gone up from when we started, and this has been a continuous process where we insist on sterilization, disinfection, especially of equipments and medical devices. We give our staff and our team CMEs and health education on how to take care of these medical devices. Remember, they are very expensive, and we need to take care of them. We realized that the use of chlorine is very corrosive, and at first it used to bring a lot of problems, but now we've learned on how to take care of these equipments by cleaning them and making sure they are cleaned after use of chlorine sterilization, and this reduces the chances of the corrosive nature of chlorine. So part of my success has been that dedicated team that I had, and maybe something just to pass to my colleagues who are listening and who are with us today. For anyone to cope with management of COVID, let's learn to have an open mind. Let's share information. We know information is power. Let's try and read more, because COVID is really changing, and the information out there is there for us to learn and build ourselves. Let's be our brother's keeper and always look upon each other and take care of the other one. Again, let's be sensitive in the manner in which we take care of our patients. And let's try to manage our own anxieties. Thank you.
Thank you very much, Zedi, for your presentation on your experience nursing COVID-19 patients. Even from the question and answer that people are actually putting up, and just knowing our nurses, we appreciate the fact that you're really frontline workers who are putting your lives on the line, even as you're managing these patients. A lot of the people are congratulating the team. Congratulations to everyone who's out there managing COVID-19 despite the challenges that are there. A comment from Professor Nduati, who's also saying very excellent presentation from all our panelists, and that right now her strong takeaway is the need for leadership and teamwork. And all the panelists here have actually emphasized on the need of teamwork and the buddy system and how they're able to keep each other supported. Most of the questions on the Q&A have actually been addressed during our presentations. I would like to give the platform to Keiza Fitzwanga or George Okuna to unmute themselves and ask one question. Unfortunately, we may not be able to give everyone a chance to talk due to the time limitations. So for anyone who's raised their hands, kindly unmute yourself and ask your question. Hello. Keiza Fitzwanga, George Oguna, Charles Waruhiu, Chege Karaoke. Lawrence Koske.
Good afternoon. Good afternoon. Can you hear me?
Good afternoon. I can hear you.
Okay. All right. Thank you very much to the presenters. That was excellent. And I really applaud all the nursing staff. You guys have this really special grace that, you know, I applaud you for all your work. And one thing that I have to mention is that nurses just have this special grace to take care of others. My question is, you know, I work I'm a critical care specialist, and even with, you know, other conditions, you know, there's always a burnout, exhaustion when you have those critically ill patients. My question is, in all the hospitals, do you have a dedicated, you know, like, do you have debriefing sessions for the nursing staff? I know, you know, you have the buddy system, look out for one another, but I'm just wondering whether there's a dedicated like psychologist who actually has regular debriefing with the nursing staff. Because man, you know, that you guys, yeah, you do a lot.
Okay, Cornelia, do you have a dedicated debriefing session for the nursing team?
Okay. Yes. Oh, sorry. I was waiting for the first person to be invited. But yes, we have a dedicated system. We have our chief psychologist is dedicated to the units that are having COVID. They're having the COVID-19 positive patients in it. So we are having a weekly debriefing session. But however, on top of that, his counterpart is standby for any debriefing session that we need in between. That now will be directed by the unit leadership. At times outside the structured weekly debriefing session, you may need a debriefing in between depending on how the day turns out to be. And it can be a group debrief or an individual debrief. So on top of the weekly debriefing session that we have as a team with our lead psychologist, we also have an individual stroke group PRN debrief with the other psychologist who is standby. We just need to communicate, and within 1 hour, he's going to be available for us. So that is in place.
Okay, thank you for that. Zedi or Maggie, do you have a dedicated psychologist? And then we'll also love to hear from Alice Maura.
Okay, so if I can say from KNH, we have a mental health team with us who reports to work with us, and as well as taking care of our patients' needs, they also take care of our needs. We have open 24-hour calls where we are able to communicate if we have any issues to our mental health and psychologists. So yes, we have a team who are ready to work with us.
Okay, Alice.
We also have the MOH and also the hospital, that is Kenyatta University Hospital, also organized on how when the Ministry of Health gave us around 11 psychologists on the ground that counsel patients, some of them who are not able to don due to several reasons, also take care of the nurses and the doctors and even the housekeeping team. So we have a set group of psychologists that take care of the nurses and every other person in the hospital. They actually have specific days for different departments from each and every other area so that all of us are counseled and even supported psychologically, because most of the people are so much anxious and just having issues from home, because we are so anxious about what is happening out there, what is happening in the hospital, and the hospital has put measures in place for us to be well taken care of. Yeah. And also maybe we also have the nurses and the doctors sitting just around and just discussing what has been happening. Maybe when they are done and when they are out there, people are able to discuss issues, and most of the times debriefing happens like on a day-to-day, because you realize that donning do not happen for so long. Like if you don in the morning, you're not donning in the afternoon. So most of the times people will have enough time to just discuss and debrief and explain the experiences inside there. And most of us go home and to rest when we are happy. Thank you.
Thank you very much for your responses. So George or Lawrence, kindly unmute yourself and ask the questions. Even as they do that, I'll ask a question from Lois and some of the people from the Q&A in terms of how do your shifts look like? A lot of the nurses, I think, on the platform want to know how your shifts look like. So if you can give us a snapshot of how they look like.
I'll start again. For us, this is Cornelia. For us, we are doing a day shift of around, I'll say approximately 12 to 12-hour shift for each shift, approximately, because during the day they come in at 7, they leave around 6, and then the night team takes over at 6 and leaves at 7. So it's around 12-hour shift per shift.
Same here at Kenyatta University Hospital. The nurses report at 7 and for the day duty, and leave at 5:30. Then because of the curfews and all, and also having the night staff reporting at 5:30 to around 7. So a 12-hour duty. Yeah, then they'll have a break for the quarantine and also to rest for around 8 days. So that they'll also have time to come in.
Okay, so if I can go in second. Hello?
Hello?
Yes,
Hello, we can hear
for
you.
us in KNH, we have, in KNH, when we started, we used to have day 10-hour shift, but due to curfew, we reduced the hours to 8 hours during the day. And at night, we have long hours, but we compensate the long hours of, so they have 8 hours, start night, for that to 7:30 the next day. So for 3 days, at least to compensate on the long hours that they are doing. But plans are underway. Now that we have different timing on the curfew, the management will change on these hours to make them even shorter. And depending on the use the hours to between 4 to 6 hours during the day, and maybe at night, making it 10 hours or 13 hours, 10 to 13 hours, depending. Thank you.
Thank you very much. George Oguna, Shege Karaoke, Lawrence Koskei, Omiri, kindly unmute yourselves and ask your questions. George. Okay.
Okay, there have been no other questions from the participants who raised their hands. We'd like to apologize first for going 17 minutes overboard, but those were very interesting pointers that we got. I hope you've learned something from that team. And we want to appreciate them. We want to appreciate all the effort that they've put in place. It was a new area for them, working new, changing circumstances and new circumstances, but we can see they've overcome. We are very excited that none of them has told us that they got infected while carrying out their duty. We are very happy about that. It is a positive thing. So I'm seeing quite a number of questions in the Q&A. Some of them, if you'd like, you can get in touch with the team. If you need mentorship in setting up an isolation facility, if you need mentorship in changing or implementing some of the things in your county, in your hospital, get in touch with the team. We would love to link you up with the team. Our key words that we got from this team is leadership, teamwork, collaboration, innovation, communication, training of staff, and having a structured approach, and having a dedicated team. Not just a team, but also a dedicated equipment. So we truly, truly appreciate this team for the pointers that we got. We apologize we're not able to get Astrid from Coast to be able to share experience, but probably next time we'll be able to hear more from the nursing team from other counties. Thank you, Alice Maura. Thank you, Cornelia Uma. Thank you, Margaret Ogonga. Thank you, Zedi Komen. Thank you, Astrid in absentia. Thank you, Jemima Katama and the whole of IPC team for organizing this and for getting in touch. We'd also like to thank the Nursing Council of Kenya for being part of this conversation. We appreciate all the efforts you've put in place to support your staff and to empower them. We appreciate all the other support systems and structures the facilities have put in place to support this powerful team. The team of nursing, we all know hospitals can't do without nurses. Actually, healthcare, they're very instrumental in healthcare, and we appreciate them for playing this role. So thank you all for listening in. Once again, we apologize for going overboard. I'd love to thank Nancy, my co-host, for handling the Q&A section and also handling the sessions. Tomorrow, I've seen a few of the questions about the treatment we are giving these patients, the patients we are encountering. So tomorrow we'll be sharing our experiences. So we'll hear from Seattle, and we'll also compare with the Kenyan picture. What kind of treatment are we giving our patients, the treatment protocols? Remember that we also have the Kenyan guideline for management of COVID-19 disease. Kindly appraise yourself with it. You'll find it available at the KNH website. It is uploaded there. The folder is called COVID-19, coronavirus, sorry. So in that folder for coronavirus, we'll be able to find the guidelines. And so we'll have that discussion tomorrow. Remember, our session starts at 7 tomorrow, 7 p.m. During the day, we will not have any session, but at 7 p.m. we'll have a session. Thank you all so much. We apologize once again. And unfortunately, your questions, we were not able to address most of them, but the panelists have seen your comments. They've seen your appreciation for them, and they appreciate. Asanteni sana. Have a good afternoon. Bye.